José Rosales Rosales. I am here to discuss the subject of acute aortic dissection and surgical simulation. You all know that the undeniable use of 3D transesophageal echocardiography in the operating room to achieve the planning and diagnosis of this medical condition. As you can see in these images, we can look at how the true lumen versus the false lumen is evaluated with these beautiful 3D images we can create in the operating room. We can even differentiate the false lumen to the true lumen by color Doppler. And this type of presentation, in this case, for a dissection which is acute, that is classified as Stanford type A, a type 1, where we look at the false lumen, true lumen, the intimal flap, and the theaside with aortic valve that was intact and had no insufficiency. We will mention this case about how cardiac tomography, one of the initial studies we will employ in the aorta protocol, to assess this patient who is 49 years old. Notice how we have two volume rendering types, external, as in this case on this side, in this quadrant where I am marking with the pointer. Look, the difference between true and false thrombosed lumen as shown by this external photorealistic effect. This means that on the volume rendering from this tomographic scan, we can see from outside. Now, the significant progress we have is exactly what is shown in this quadrant where I am marking now on the right side of your screen, where we can observe the key element, the entry tear of intimal damage in the ascending aorta, as you see here. We can also see the intersection. In other words, this is a volume rendering where we can not only carry out transillumination and the photorealistic effect, which is the most significant on the intersection of the aorta. So, this allows us to use the TEM classification for surgeons. It is included in the 2024 guidelines for surgery, where with this classification we hold type T concerning whether it is type A, type B, or type not A, not B, concerning E, which represents the visible or invisible entry tear. The M in relation to the patient's poor perfusion, yes, present or not. One of the significant advancements in tomography is the automated measurements by artificial intelligence. Notice that in this case, we are conducting an acquisition that was done on our patient to see in an automated manner, looking from the ascending aorta to the aortic arch, descending aorta, even going to the iliacs, and where artificial intelligence allows us to make measurements automatically depending on where you place the sample point. The machine will determine the max and MIN diameters of the lumen. Yes? This represents a significant advancement because knowing these maximum diameters is essential for intervention. What is the new thing that we are doing at this moment? We are using the artificial intelligence from that same acquisition in software, where we can directly request that all the structures be isolated, that do not include vascular or cardiac structures. We ask the artificial intelligence to only view from the iliacs to the aorta vessels, ascending an arch And through that generation by artificial intelligence, we can generate an STL model. The STL model is what you are currently observing in this instance. Now we see the quadrant. In this right box, we see the frozen elephant trunk planning, in which it is a Dacron prosthesis that we have constructed using the software that covers the whole ascending aorta and the arch. And evidently, we also have the shape of this prosthesis that we designed in the program can go down to the descending aorta, as we will see shortly. Look, we are there, ensuring that the branches from the aorta through the arch part also reach. To be seen now, as we are seeing too, the prosthesis that will go towards the descending aorta. In the quadrant you have on the left side, you can see how it is already in motion. Even we can determine if there is any degree of deformation in that prosthesis. The endovascular prosthesis that will be placed towards the descending aorta and the prosthesis we are putting in the operating room, which is the frozen elephant trunk, which is the part that is going to help us to fix, right? We are performing a resuspension of the aortic valve with respect to the root and the valve, and placing this Dacron prosthesis that goes to the ascending aorta and arch, and that will communicate with this other prosthesis that is towards the descending aorta that you are looking at right now. This surgical plan, as you can see now, we are in the operating room, and before entering, the entire team had to work the previous night to process the images from both the 3D transesophageal echo and the CT scan. And before to the surgery, the entire team can gather to collaborate, to see the best strategy with which to intervene on the patient. For those who have already viewed the images from the transesophageal echo 3D that we did regarding the ascending aorta, there was uncertainty regarding whether what had happened in the ascending aorta, whether it was dissected or not. And then the tomography clearly showed us that there was a dissection, that it was classified as Stanford A. Yes? We're in the operating room. See how interesting it is. We are already doing. We are in the operating room after having done the planning, and we are performing this surgical technique where it combines the frozen elephant trunk, which is to perform this resuspension of the roots. It is only placed in the Dacron prosthesis. And this Dacron prosthesis, the entire ascending aorta and arch, is tasked with having two additional tubes, which provide the transit for the supra-aortic vessel and then connect to a different prosthesis that will go toward the ascending aorta. Well, what are the possibilities and advantages of simulation with artificial intelligence and virtual reality? As you can see, first, the diagnosis of the intimal entry tear. In the dissection with the use of photorealistic effects, this is truly innovative, because up until now, everything we had in tomography was just in color, or the volume was just colored externally. The new thing is that now we can do it in color, but internally, meaning seeing the intima where the tear is and its sizes. This is crucial because often the methods we used in the past, which were black and white, are no longer effective. Is no longer the case. It is no longer the best method. Therefore, it is clear that both surgical and interventional planning is essential. Keep in mind that this is carried out with a full team of specialists in both cardiac imaging and surgical procedures. This software also enables the design of Dacron prostheses in terms of size, shape, and curvature, like in this case using the technique known as frozen elephant trunk. It's as simple as spotting an elephant, requesting ChatGPT to provide you a picture of a frozen elephant in the tomograph. Well, we have wanted you to see how currently artificial intelligence can do all of that for us. And I wanted to ensure I didn't say goodbye without first using Dr. Arturo Evangelista's platform to warmly invite you to the course, which he established. This is the 45th echocardiography course and the third multimodal cardiac imaging course at the Vall d'Hebron Hospital in Barcelona City. There's no better place than this platform for you to join us in presenting at the tomography workshop. I wish to give you a small token from me, and for each and every one of you AortoHub platform professors, the Android application so you can view the STL file here in this quadrant. You can scan this QR code. You'll download the STL file, and with this app, you can view the STL file in 3D on your mobile device. My name is José Rosales, and by scanning this QR code, you will be able to contact me where all my social media and WhatsApp information is. Plus, mail. And with this, I would like to say goodbye and thank you. These minutes to share these images with you. Thank you very much.